Assalamu alaikum rahmatullah. Good morning, everyone. It's my pleasure today to be in this osteotomy session with Professor Adrian and Professor Hisham. First of all, I would like to introduce Professor Adrian to everyone in the hall. He is a professor in the UK, Northampton University. He is the founder of Knee Preservation Foundation. He has led many courses in the UK, and he is the founder of Basingstoke Osteotomy course, which had been run for several years. And he is also the founder of London Osteotomy course and had shared in many scientific articles about the field, and he is one of the internationally renowned figures in osteotomy. Adrian, thank you very much for coming. I also would like to thank Raghbir. Unfortunately, he didn't make it, and Adrian is going to cover his presentation. First of all, I would like just to give a hint about what's meant by to stand the test of time. More than 20 years back, when I was preparing for my exams for the fellowship, I read a word about Bassini repair. Which had stood the test of time. Bassini repair had stood the test of time. Bassini has invented his technique for hernia repair 1888. And general surgeons since then used to do this technique successfully. So this is a very high success. They had been doing this repair successfully for more than 100 years. It stood the test of time, and I think osteotomy as a concept as well had stood the test of time, and this is what we're going to discuss. We have some history about osteotomy. I'm not going to be in the details, and Professor Adrian has a presentation about history of osteotomy, very detailed, and it is on the Knee Foundation website. The recent history after 2000s, we have international renowned experts like Roland van Heenvaarden, Alex Stobley, and Poudou, of course. Everyone knows Poudou plate and Al-Assal plate, which is the modification of this, Philip Lobenhofer and others. So it's a full hierarchy of things around this procedure. Basingstoke knee osteotomy masterclass held for several years at Luxembourg Osteotomy Congress, and so on. So, first of all, I would go to the basic science, and we have a couple of articles published recently by Henning Madry. He is a professor in Saarland University, and he is very interested in the basic science related to knee surgery. And he published this the last year, Analysis of Spatial Osteochondral Heterogeneity in Advanced Knee Osteoarthritis, exposes influence of joint alignment. So on basic science level, he identifies site-specific effects of various malalignments and supports the clinical concept of therapeutic unloading. Another article by him as well, very recently published, Axial alignment is a critical regulator of knee osteoarthritis, as he provides evidence of osteochondral recovery upon unloading symptomatic isolated medial tibiofemoral knee osteoarthritis associated with various malalignments. So on basic science level, there is an evidence that the loaded compartment would probably flourish and start somehow some kind of recovery. Going to clinical work, and I start with this article published 2021 in the KESTA, discusses the long-term survival and patient-reported outcomes after high tibial osteotomy for medial compartment osteoarthritis. It discovers they go to excellent long-term survival rates for more than 15 years in the majority of patients. Going to some factors probably affecting the survival of osteotomy procedures in general, probably the age. We have this article, 95% survival in young patients for more than 12 years. And if someone is going to tell us this is young people, no problem to do osteotomy with them. Another paper here revealed that there is no difference between young and old age as long as the knee is still having the potentials for survival. Probably more than 60 years in this article, and another article concluded that there is no definite age at which one should go for HTO. On a population-based study, it may provide long-term survival in selected patients. A Finnish registry discovered the figures of around 90% for 5-year survival, 73% for 10 years survival. Another article, 10-year survival rate 87%. Another one, 87 for 5 years, 87 for 10 years survival, and 85 at 13 years. And good to excellent results in 10 to 20 years in this article. Again, 78% in 10 years. If we look at another factor, severity, and this article discussing the effect on knees having radiological kissing lesion or a bone-on-bone, as we say, it also discovered the effect of mid to long term. If we did osteotomy plus, these couple of papers discusses the effect of adding some kind of cartilage treatments with osteotomy, and it seems that the osteotomy itself is the one playing the major role in the improvement of patient, and additives would probably do not a lot of difference. If you go to the lateral side, lateral closing wedge, and see the survival rate of patients undergoing lateral closing wedge for proximal tibia, in this article it is 10 to 16 years survival. And here 90% at 10 years, 83 at 15 years, and 75 at 20 years. So it's really long-term follow-up. And here in this article as well, 15 years follow-up revealed 92% improvement, 87 5 years, 79 at 10 years. How about the distal femur? This work has been done by Professor Adrian and his colleagues, and it revealed 90% survival for 10-year survival rate, 90%. Another article for the distal femur, 90% for 5 years, 73% for 10 years, and the outcomes look to be not very much different between the closing and the open wedge of the distal femur. So it's the matter of concept, not the matter of the technique itself. Going to double level osteotomies, Schroeter is another figure performing high volume of osteotomies in Germany, and he published this article recently, and showed the effect on the joint line, how is it too bad to the patient to be walking on an oblique joint line, and probably this is one of the privileges of double level osteotomies. Another article for double level osteotomies, systematic review of 6 papers, and the most important finding of this is the relatively low complication rates of double level osteotomy and satisfactory post-operative PROMs. So it looks in general to be like this graph. The overall survival rate probably would go to somewhere around 85 to 85% for 15 years. The last one, this paper had a very nice comment by its end, recommending knee surgeons to perform more osteotomies and not to be under the pressure to perform arthroplasty surgeries. Regarding indications, it's very wide list, and it's going to widen day after day. I'll go to some case examples of our very old cases. This is around 15 years back, and still standing. Another patient whom we did him repair of an osteotomy that had been done somewhere else, delayed union, valgus deformity, reversal of the slope as can be seen, overcorrection. So we did him revision several years ago, correcting the slope, correcting displacement, healed in the end, and regained the corrected position. Another patient, we did her osteotomy for an old one. So sometimes osteotomies, the old osteotomies, did some kind of deformity of the proximal tibia, as you can see, and obliquity of the joint line. And this patient was not happy at all. And we did her correction by a double level osteotomy. Massive defect that has been also several years ago. As you can see, the major defect on the MRI. Even before the advent of Tomofix plate, we did him this double level osteotomy, and this is the video on the left hand side, and this is the post video. We did him arthroscopy for some reason, and we found this amazing healing of type 4 cartilage defects after a few months of the osteotomy. Lastly, we start doing osteotomy for even advanced cases for young age, of course. This patient is 48, he's a physician. His life stopped, and this is on the right hand side the medial compartment, on the left hand side the lateral compartment, which looks not too bad, and we did him a double level, and his life started to be resumed back. He traveled once more and working once more. Similarly, another patient. This patient is 37 years old, and this is the pre-X-rays, and the videos on the right-hand side is the lateral compartment. We offered him a double level as well. Walking on the left side without a stick, 6 weeks post-surgery. So to conclude and leave some space for discussion by the end, osteotomy has been vastly studied, has stable results and robust evidence in the literature. The indications and selection criteria are extremely important when you contemplate doing an osteotomy for a patient. We should have a proper indication and to select the proper patient for the procedure. If it is done correctly, even though differently by different techniques, we probably have the same results. So it's not the matter of the technique as long as it has been done correctly. It's the matter of the concept of correcting the coronal malalignment, and we should be understanding and planning well before doing our procedure. Thank you very much.